Okay, so welcome everyone to our second last session of the day on neoadjuvant therapy, transforming the surgical landscape of pancreatic cancer. It's a pleasure to introduce our two speakers this afternoon. First, we have Dr. Beatrice Anton. She is a medical oncologist specializing in gastrointestinal and neuroendocrine tumors. She is actively involved in patient care, clinical trials, and multiple clinical and translational research. Beatrice is currently pursuing a PhD at Universidad Complutense de Madrid, as well as a fellowship at Princess Margaret Cancer Center in Toronto, where she is pursuing advanced training in gastrointestinal tumors. And in person with you, you should have Dr. Pablo Serrano, her co-panelist, who is an associate professor of surgery at McMaster University. He joined the Department of Surgery in 2014, and he's an active researcher and scientist at the Escarpment Cancer Research Institute and has led several trials within the Ontario Clinical Oncology Group. He is also an associate member of the Centre for Discovery in Cancer Research at McMaster University, focusing on comprehensive translational studies that inform the rational development of combinational therapies for cancer treatment. So please give a warm welcome to both of our speakers, and I think we'll start with Dr. Anton's presentation.
Okay, can you hear me properly, right?
Yeah, we can hear you.
Perfect. So first of all, good afternoon to everyone. Thank you for the organizers to giving me the possibility of giving this talk. So it's been a really, even if I'm sorry I cannot be there, but it's been really helpful. I think the multidisciplinary congress are the best, and I think most of the talks have given us pretty much helpful, and it has been outstanding speaker. So thank you for including me in that. I'm going to try to review. My talk is going to be more theoretical about neoadjuvant therapy and how we are transforming the landscape in pancreatic adenocarcinoma. So these are my disclosures. I'll start with a brief overview of PDAC incidence and classification, although you have been talking about it. I just try to be brief. Regarding perioperative treatment, our goal is to try to improve surgical outcome. As you know, uncontrolled metastatic disease, which has shifted the field toward integrating systemic therapy both before and after surgery. Also, adjuvant therapy remains the standard, and I'm going to talk a little bit briefly because it is the rationale in which neoadjuvant therapy is increasingly used. And I will briefly discuss also its role in resectable and borderline resectable tumor, followed by a short overview of when it is coming next in the field, which you also have summarized, so I will try to not repeat very much. First of all, to understand this important concept, as you have mentioned before, it's important to acknowledge that pancreatic ductal adenocarcinoma, PDAC, is projected to become as one of the leading cause of cancer-related mortality by 2030. Despite advance on oncology, outcomes remain really poor. As Dr. Maleki has told, pancreatic cancer, the 5-year overall is only survival is only 12% of the tumor. In metastatic disease, survival drops dramatically, barely 3% of the patient. But even in localized disease, 5-year survival reaches just 50% of the patient in locally advanced, and even all early disease tumor, it is only around 40% of the tumor. Traditional patients with this anatomically resectable disease have received upfront surgical resection followed by any kind of systemic chemotherapy or radiotherapy, but our understanding of PDAC pathophysiology have shifted over the past decade, and that is why systemic disease is likely to be present even in patients without radiographic evidence of distant spread, and ensuring patients receive systemic treatment is likely critical for disease control and optimizing long-term survival. As such, while surgical resection remains necessary for definitive cures, there are several studies in which are exploring the optimal timing and treatment regimen for systemic therapy in unresectable PDAC. So I'm going to try to, as you know, surgical assessment of resectability, you maybe know better than me, is primarily driven by anatomic feature, ascertained via high-quality cross-sectional pancreatic imaging at the time of diagnosis. Also, it's important to assess that multiple resectability guidelines can add to the challenge of ideal treatment management of PDAC patients, as evidence can vary by inter-observer agreement among some times radiologists and surgeon. And we will mainly focus on resectable disease and borderline resectable, which is mainly in patients without any kind of vessel involvement, and borderline in which we can see some venous involvement and tumor involvement of the mesenteric arterial disease or celiac axis. Why is important? What is the rationale for perioperative treatment? So, as I mentioned before, systemic disease is often present even in patients who show no radiographic evidence of experience. So, patient selection is therefore essential, allowing us to identify those with chemo radiosensitive tumor who may experience dose changing and ultimate benefit from surgical resection. And also, is not that well described, but also prehabilitation before surgery, focusing the nutrition or exercise can improve physical fitness and reduce hospital admission and lower postoperative complications such as fistulas or infection compared with the upfront surgery sometimes. So traditionally, as I have introduced at the beginning of this talk, guidelines for PDAC have recommended upfront surgical resection followed by adjuvant treatment in those patients with resectable and borderline resectable disease. This recommendation is rooted in outcomes reported for a broad evidence-based examining adjuvant therapy. I'm not going to get into much detail, but it's important that we just assess some of the first randomized trial. First of all, one of the American one in which investigated the potential role of adjuvant radiation with concurrent fluoropyrimidine, which is one of the systemic components. Well, for example, this study was terminated due to a poor patient accrual. Imagine in 1985, analysis of the first 43 patients demonstrated a statistically significant near doubling of median overall survival among patients undergoing adjuvant therapy. Also, we have the European study in which we recruited more than 500 patients and evaluate also adjuvant chemotherapy and chemoradiation after PDAC resection. This is a little bit complex because this study is like a 2+2 factorial design, but in general, the result that I wanted to point out is a significant survival was described, benefit with chemotherapy, while chemoradiation didn't offer this benefit. Despite the criticism and also the outdated radiation protocol that this study used, the study confirmed that 5FU, this kind of chemotherapy, can be effective in adjuvant treatment rather than chemoradiation. COCO trial, also well known for everyone. Phase 3 trial, also adjuvant therapy that randomized patient with resected PDAC to 6 months of adjuvant therapy versus observation. Also, gemcitabine significantly improved disease-free survival, 13 months versus 6 months, and so a modest but significant overall survival benefits, 22 months versus 20 months. So, with this kind of all the kind of limitation that we may find, these studies established gemcitabine as a standard adjuvant therapy after PDAC resection. And what about comparing both 5FU and gemcitabine? So the SPAC trial was also a large phase 3 randomized study who tried to compare these two adjuvant regimens that has been seen helpful in the past, and it showed no significant difference. As you can see, the overall survival between two regimens, survival was roughly 23 months in both groups. However, toxicity, they were reported as much as at least more severe in the 5FU arm rather than gemcitabine. But as you can see, progression-free survival and quality of life outcome were similar across both treatments. I also wanted to point out more about other gemcitabine-based system. This has been proven these years. Or we have other kind of treatment. I'm sorry, and I wanted to point out other kind of treatment. Also, the first Prodige 24, which was a French and Canadian study, and assessed the fulfillment regimen versus the adjuvant regimen based on gemcitabine monotherapy, and it was improved. The triplet regimen improved disease-free survival, as you can see, and also overall survival and statistically significant. There is also a Japanese trial, which I'm not going to get into, comparing gemcitabine versus another kind of fluoropyrimidine, which is ACE1. These experimental arms show a beneficial, and we also have some gemcitabine regimens with adjuvant and nab-paclitaxel, which also show different survival, better disease-free survival than gemcitabine alone. So gemcitabine, what can we say apart the FOLFIRINOX triplet? Also gemcitabine, it's a standard option for patients that can now be eligible for FOLFIRINOX. On that regard, this has been published this year, the final result of the ESPAN phase 3 trial that, as many of you know, is gemcitabine immunotherapy comparing to the experimental with capecitabine. And we also saw that there is an improved median survival with gemcitabine, with the combination of gemcitabine, capecitabine versus gemcitabine monotherapy. Also, they did some exploratory analysis in this, and this may be particularly efficacious, the combination, in higher R0 patients and also in lymph node negative patients. So the message that we have on adjuvant therapy is that better considered in resectable disease. Current guidelines recommend FOLFIRINOX, the PRODIGE trial, in which they reach the better survival for patients with good performance status, but it is also good to know that gemcitabine-based regimen, also with nab-paclitaxel or fluoropyrimidines, can be viable for patients with the clinical condition are not that suitable. What about the neoadjuvant? So neoadjuvant, is an alternative strategy from upfront resection. Recent trends show an increasing use as an approach in localized PDAC, and also multimodality treatment and personalized medicine have something to do with that. And given the success, this happened or disappeared because the continuous success of gemcitabine and FOLFIRINOX in some of the previous studies which I presented in the adjuvant setting. So the interest start growing for studying this using perioperative approach. There has been some predictor of clinical benefit which are currently lacking, but as you know, we are using the CA 999 markers, tumor size, lymph node ratio, and modified prognosis score that may serve as a predictor of survival benefit and could be integrated in the clinical decision-making process while considering neoadjuvant chemotherapy versus upfront surgery for a resectable or borderline resectable PDAC. I'm going to start focusing more in resectable tumor, which you see that are more of the viable ones in terms of the goal of curative, and resection are more likely to be assessed. So for what we know about neoadjuvant treatment on these cases is we have early studies in the 90s that suggested neoadjuvant chemoradiation could enable successful resection and improve also margin status with potential survival benefit that were presented in 1992 and 1993, which I'm not going to get into, few patients, and it was like a preliminary data. So in terms of the phase 3 trial, more important in the adjuvant, let me share with you the PREOPANC trial, which is a landmark study from the Dutch Pancreatic Cancer Group, published in 2022. This trial assesses a key question: does neoadjuvant therapy improve outcome in patients with resectable PDAC compared to the traditional surgery approach? So to explore that, more than 200 patients were randomized. One group proceeded directly with surgery, followed by adjuvant capecitabine, while the other received perioperative gemcitabine-based chemoradiation before surgery. So in the overall population, as you can see in the Kaplan measure to your left side, no significant difference in the median overall population between neoadjuvant chemoradiotherapy arm and the surgery arm was observed. However, where patients were stratified, an important signal emerged, and they described that among those with borderline resectable disease, preoperative chemoradiation resulted in significant improved survival and a longer locoregional failure-free interval. So another important point of this study is that patients in the neoadjuvant arm were more likely to complete systemic surgery, and that is critical because we know that many patients can struggle to get adjuvant treatment after this kind of major surgery. So of course, this trial has some limitation, but and also it used gemcitabine monotherapy, which isn't our standard today. But despite everything, I think PROPAN gave us a kind of a strong evidence that neoadjuvant therapy improves survival quality and can improve survival quality and long-term outcomes, especially in this kind of disease. Now let's look other study, the SWOG 1504, which was published in 2020. So this was the first, would say the first prospective multicenter trial to evaluate modern chemotherapy regimen in terms of the perioperative setting for resectable pancreatic cancer, and patients were randomized to two arms. So first arm was uh, total FOLFIRINOX 6 cycle before and after surgery, and the other one was based on gemcitabine plus nab-paclitaxel, 18 cycles in total, 9 before and 9 after surgery. So impressively, 80% of those resections were R0 and about one third, so pathological, respond to perioperative treatment. When we look at the survival at 2 years, overall survival was 47% of the FOLFIRINOX group and 48% of the in the gemcitabine nab-paclitaxel group. So essentially, no significant difference. So while this kind of study didn't demonstrate an overall survival advantages, it did show that both regimens are feasible, were tolerated, and non-inferior in the neoadjuvant setting, and can have better outcome in terms of higher resection rate, which I think it's important for us. So the other PreoPanc trial that I showed you before was able to prepare for the PreoPanc 2 trial, which is also phase 3 study evaluating whether FOLFIRINOX could outperform the standard gemcitabine-based chemoradiotherapy regimen that we have talked before. So among 375 patients with resectable and borderline resectable PDAC, the trial showed no significant difference. As you can see, both arms has 21 month of overall survival are even pretty much the same resection rates. But this result highlight that maybe FOLFIRINOX did not improve outcome and left the role of radiotherapy in resectable cases still uncertain. So more recently, we have the Norwegian Pancreatic trial, which evaluate perioperative FOLFIRINOX 4 cycles before and 8 after versus traditional adjuvant therapy in patients with resectable PDAC in the intention of to treat analysis, median overall survival favor, as you can see here, on the contrary, upfront surgery group, and per protocol analysis, they did this per protocol analysis, as I told you before, an R0 and N0 resection rate in the perioperative arm were higher, but no survival benefit was observed. So overall, the study suggests that perioperative FOLFIRINOX does not clearly improve survival compared to the traditional adjuvant approach on resectable PDAC. So pretty much said about resectable, mainly phase 3 study trial. So I'm going to focus a little bit more about borderline resectable, in which, where there is a kind of tumor in which the goal is to have curative receptive, but the arterial and venous involvement are a little bit more tricky. So usually perioperative therapy is preferred in this kind of tumor. So the SPANC5F trial was an international phase 2 that randomized patients with borderline resectable PDAC. I think this was pretty much interesting study to either surgery or 3 preoperative regimen, 2 cycles of gemcitabine capecitabine, which has been assessed at the SPANC trial in the adjuvant setting, 4 cycles of FOLFIRINOX, or chemoradiotherapy with capecitabine. So, and also the primary endpoint of this study is important, wasn't the overall survival, which was studied on secondary endpoint, but the resection rate, which is different in terms of the other study that we have presented. So all patients who underwent resection received adjuvant therapy, though no particular regimen was mandated in the study protocol. So as you can see here, there was no statistically significant difference in resection rate for immediate surgery versus neoadjuvant treatment, more likely to be around 55% and 60% of the patient, and no statistically significant difference. And also, if we look at the secondary outcomes, the overall survival, so as you can see here, the overall survival was higher in the perioperative therapy groups from gemcitabine on the FOLFIRINOX versus the chemoradiotherapy group. So while the study population was limited to borderline resectable patients, I think this that again point toward a surgical benefit with perioperative surgery versus adjuvant therapy alone, and can suggest that systemic therapy may be greater than radiation. Among the neoadjuvant treatments, as I mentioned before, FOLFIRINOX demonstrated the best survival at 1 year versus immediate, although toxicity, we know that it was higher, but overall was manageable. So I think this is one of the first studies that more clearly suggested that neoadjuvant therapy should be considered for patients with borderline resectable pancreatic cancer. The Alliance study is another attempt to elucidate the utility of FOLFIRINOX regimen, as well as the value of including radiotherapy for resectable or borderline resectable disease that we have assessed. It doesn't seem to add much in that scenario. So patients were randomized to 8 cycles of FOLFIRINOX or 6 cycles of FOLFIRINOX, followed by a stereotactic body radiation. So it was RBRT, and underwent resection if patient hasn't had progress, and then receive an additional four cycle of systemic therapy. So for a total of 130 patients enrolled, and in the chemotherapy group, 32% of the patients proceed to surgery with an R0 rate of 80%. By comparison, only 19 patients in the radiotherapy group underwent resection with an resected rate of 74%. Median overall survival, which, as you can see on the Kaplan-Meier table, was 29 months in the chemotherapy group versus 17 months in the chemotherapy and radiation group. So I think this study also established a strong foundation for FOLFIRINOX as new comparison standard for neoadjuvant therapy in borderline resectable PDAC. What about the neonax? So the neonax is also current trial. It's a German trial, phase 2, which randomized 120 patients to receive preoperative gem paclitaxel or upfront surgery. So as you can see, it shows like disease-free survival was low in both groups. So, and also resection rates weren't too much. Too much. So I think it can be said that no survival benefit despite the higher resection rate, and neoadjuvant therapy can be better tolerated, while adjuvant treatment, again, as the other trial that we have talked about, cannot be delivered because patient after upfront surgery usually doesn't find too well. And what about the PRODIGE 29 Neopanc trial? I think it's also important to see because this is a trial in which provides a significantly longer progression-free survival if we compare gemcitabine and with it was randomized to FOLFIRINOX. I think in conclusion, as you can see a little bit on the Kaplan-Meier graphics, FOLFIRINOX demonstrated better, superior results in terms of disease control, but it doesn't clearly improve survival. So this highlights the need to explore alternative pathway on other treatment strategies to determine the optimal treatment, but because the response doesn't seem to be all in terms of survival at the end. So what about the ongoing trials? So we know that the PREOPANC 3 is recruiting, and also the Alliance 2180, 106 are 2 ongoing studies examining perioperative FOLFIRINOX against upfront surgical resection, followed by adjuvant therapy in a phase 3 setting for patients with resectable pancreatic adenocarcinoma. In this case, PREOPAN is examining perioperative 8 neoadjuvant, 4 adjuvant cycle versus adjuvant or 12 cycle completed in patients with resectable PDAC. So the primary outcome in this case is overall survival, and secondary outcomes, resection rate and progression-free survival as usual. And similarly, the Alliance trial, which is based in the United States and Canada, are also evaluating perioperative FOLFIRINOX in patients with resectable PDAC with the same primary and secondary outcomes. Following surgery, I think this is quite important, and I want to highlight one of our works, which was presented by my fellow Ronan McCauley, and it was from who works with Dr. Knox. It was presented in the ASCO trial. I think the Neopanc study, for instance, has explored the use of some biomarkers when we randomize when patients receive neoadjuvant treatment and also surgery and complete adjuvant. As we can see, it is not only based on regimens, neoadjuvant treatment in terms of chemotherapy or radiotherapy, but also can have some biomarkers. And they presented that GATA6 expression can be a predictive marker for preoperative chemotherapy response, because patients who has a higher rates of GATA6 expression, so higher response rate and higher survival than the ones that have low expression. So again, maybe some biomarkers can open a window to design strategies not only based on chemotherapy or radiotherapy or based in surgery outcome, but also in some of the biomarkers, some of the molecules that tumors are presenting. So, as you know, there is currently a paucity of prospective data exploring the immunotherapy as a neoadjuvant setting also, but preliminary data suggests potential benefit of this approach if it is applied in a tandem with radiation or chemotherapy, such as targeting the pancreatic tumors stroma, which in pancreatic adenocarcinoma seems to be one of the main limitations for the systemic treatment to be functional. So in that regard, we have some of components, for example, pamrevlumab, which is a monoclonal antibody targeting TGFR, which has been explored to be a promising with preclinical data and early phase clinical data. So also we have another kind of trial which has been presented previously. Vaccine, there is a phase 1 platform trial evaluate the role of cancer vaccine with some chemotherapy components such as cyclophosphamide or even immunotherapy, limolumab. I think again, and also an anti-CD137 agonist antibody, which is called urelumab. I think neoadjuvant treatment are followed by surgical resection and then adjuvant standard of care chemotherapy. So it can be important to assess if all complete neoadjuvant and adjuvant treatment with some new and standard approach can be beneficial for this patient. And also, the talk is going to be that long, but also I want to point out to you the recent advent of liquid biopsy that continue to shape clinical management in patients with gastrointestinal and gastrointestinal malignancies, and also can serve as an effective and serial repeatable method for therapeutic monitoring to identify, for example, early relapse or patients that are not responding well to treatment. What about future therapies? I think we need more data to arrive to that, but also KRAS mutation, as you have mentioned before in other talk, are really important and develop pretty nice results. So I think for now it's mainly used in unresectable or metastatic setting, but I think it will come to the neoadjuvant setting based on the pretty good result that we have until now. And some of the trial that are after recurrent is the DORA trial, which I think most of you know, that is investigating the impact of nivolumab on and oleclumab in PDAC to determine the increase of immune cell infiltration. And oleclumab, durvalumab is also immunotherapy antibody, and oleclumab is a molecular antibody that binds and inhibits the activity on CD73, which has been studied to be one of the most important, the stromal pancreatic tumor cell. We have also the ablet study using the ablet dose of radiation, which is also in Canada, and we also try to assess the role of radiation in this kind of patient, in which resection, in which resection in PDAC cannot be assessed after. And I also want to point out briefly about the efficacy of neoadjuvant autogene plus atezolizumab with FOLFIRINOX versus only adjuvant setting with FOLFIRINOX. This autogene cevumeran, which is like a messenger RNA-based individualized neoantigen specific immunotherapy design from tumor-specific somatic mutation data and obtained that is obtained from tumor tissue of each individual patient, which underwent surgical resection to stimulate T cell response against some antigens. I think this trial are pretty good, but also I want to introduce that it is again adjuvant setting. So if we have some neoadjuvant treatment and this kind of vaccine and this kind of design treatment are also based on the tumor cells. So this cannot assess sometimes in neoadjuvant setting because we don't have much tissue to design this kind of treatment. So I think this trial represents an important step, but in advancing treatment in pancreatic tumor through therapeutic approach. What about advantages and disadvantages? So I'm going to try to resume what we have talked before. So surgical outcomes in terms of neoadjuvant approaches can be improved. Rather than upfront recent and radiation treatment, we have many trials that has described higher rates of margin negative resection and also less complication. Lymph node positivity is lower also if patients undergo systemic treatment prior to therapy, and also we can test some of the tumor biology and improve patient selection for a surgical intervention. On the other side, there is another school in which neoadjuvant approach could be seen like a delay in surgical intervention and increasingly the theoretic risk of disease progression. Also, some patient needs some endoscopy, ultrasound, biopsy, often having samples errors and false negative, leading to repeat procedures and possibly treatment delays that can be important. And targeted therapy usually require more tissue, as I told you before about the vaccine, to design this kind of treatment, which can be another tricky in terms of neoadjuvant treatment rather than adjuvant. And I just want to finish it with this recently meta-analysis, which has been published in this year, and demonstrate a survival benefit of neoadjuvant treatment, especially for borderline PDAC. They try to summarize most of the stuff that I have talked to you about, and they mainly resume that neoadjuvant treatment should be considered standard care for patients with borderline PDAC disease. The doesn't seem to be the same as you can see for resectable disease, although further trial I think are needed to identify the optimal regimen before and after the surgery. And I think the main message that I want you to have is that the disparity in delivery of systemic treatment between neoadjuvant and adjuvant regimen in PDAC is perhaps one of the most compelling rationale for neoadjuvant approach. As long as we can know neoadjuvant therapy is increasingly favorably with higher risk, less spread, reduced surgical complication, and also early tumor biology assessment, adjuvant therapy remain well supported in some cases and also can reduce the uncertainty for patients and are provided. And also we have future targeted and immunotherapy that may shift treatment back toward to adjuvant approaches, but let's see how we can work in terms of adjuvant and adjuvant treatment. I think the complete treatment is going to be most beneficial for most of the patient regarding localized advanced pancreatic adenocarcinoma. And that is it.
Thank you very much. I don't know if anyone in the room has any questions, or we'll move on to the second second presentation by Dr. Serrano, and then after we'll leave some time for questions. Okay.
Thank you.
Thank you.
Thank you, everybody. That was a great presentation. Beatrice, I guess I just want to pick your brain now. What do you think? Can you hear me well?
Yeah.
So what do you
I'm sorry,
think?
it was a little bit long than I expected.
No. So I'm just thinking, I mean, when we're trying to figure it out, neoadjuvant therapy for pancreas cancer, it seems that obviously we have these two different patient populations, the resectable and the borderline. At
Yeah.
least in my institution, it seems that everybody with borderline disease, especially if they have some sort of arterial involvement, we tend to give neoadjuvant therapy. Like, this is not a question that we ask patients. We sort of discuss this at rounds. We say there is, borderline disease, and this patient should get neoadjuvant therapy. And we talked to the patient and we said, you should get neoadjuvant therapy. Is this what's happening in your center?
Yeah. Essentially, I think we are trying to be more involved in trial in terms of resectable disease, which is more like in which there are more trials regarding immunotherapy and other kind of targeted therapy, which I think it can or it could be potentially beneficial. But in borderline disease, is mainly based on regimen essentially with FOLFIRINOX. And even if there are patients which are not well enough, we tend to use some gemcitabine-based regimen. But I have seen in sometimes, as you are talking about the resectable and borderline resectable, I have had the opportunity to work in different centers, and sometimes for some of you surgeons are resectable, for other kind of surgeons are borderline resectable. So sometimes the approach for the same case can be different if the patient, for example, asks for a second opinion in other centers. So it's kind of a complex term sometimes.
And for resectable disease, I think in Canada, it's a little bit easier for us to choose because it's not that we can give neoadjuvant therapy for patients with resectable disease. So I did a little tour of America in the different centers, and I went to the Mayo Clinic, and I went to Minnesota. I also went to Florida, and then pretty much every patient with resectable disease was getting neoadjuvant therapy. So this, the clinical trials that we're talking about, especially the Alliance clinical trial, was not going to be able to be performed there because every patient was getting neoadjuvant therapy. And here in Canada, we didn't have the option for neoadjuvant therapy because of funding issues. I guess I wonder here in London, what is happening, Dr. Leslie? Yeah. So when we look at, can you guys hear me?
I'm sorry, I cannot hear well.
Yeah, he's going to get the microphone.
Thank you. Perfect.
So it's Ken Leslie from London. We're really aggressive with neoadjuvant patients, and the definition correctly of borderline is quite variable. So we take the American HPBA, which is just any contact is borderline. And then we do like other centers, there's also biochemical borderline patients. So a high CA19-9 will make them borderline. And then there's patient factors that will make them borderline. So we're not just looking at imaging by NCCN, because we think that more patients should get upfront neoadjuvant.
Yeah.
So we stretch it.
Right.
And we call all those borderline either radiologically or biochemically.
And what has been your experience with giving patients that are patient factors borderline, given neoadjuvant therapy? Are they able to get it and get the surgery at some point, or not really?
So we found, just like the other studies, our R1 resection rate has gone down.
Yeah.
Our node positive rate has gone up. A negative laparotomy or an open and closed Whipple has gone down. So we're kind of weeding out those ones that we operate on, do the Whipple, first scan, 3 months later is the disease everywhere.
Yeah.
So we're weeding those out. And we're also weeding out the guy get through their chemo and be strong enough. So if they're a little bit frail, that they would have been frail for surgery, they're frail for chemo and don't get to surgery. Just similar to if we did a Whipple and don't get to adjuvant, it's because they're frail and don't get there. And a lot never got to adjuvant therapy. And that's the problem with a lot of the studies.
Right.
So it's kind of a weeding factor.
Thank you. So I think, back to, what I wanted to bring into my presentation is when we started the Alliance trial, which is this, 352 patients comparing neoadjuvant versus adjuvant therapy with FOLFIRINOX, I thought it was a slam dunk. I thought, well, this study is going to be very straightforward. Everybody's going to do better in the neoadjuvant, because I really thought, pretty much like you, that the positive and the advantages are very clear, and the disadvantages were mostly related to maybe patients are not going to do so well, they're not going to make it to surgery, or perhaps we have to repeat the biopsy. That were kind of technicalities. We did then, though, the Alliance trial, we had randomized it. We just finished enrolling recently, and we enrolled approximately 13 participants. And the story that I got from those 13 participants was a little bit different. Obviously, we don't have the results, but I wanted to show a little bit of what we saw, okay? And I don't want to get this is obviously we have success stories, but we also have the stories that I'm going to bring. Can we put up my slides, please? All righty, let's see, the green one. I think, that was just the definition of what we've already discussed. It was nicely presented. So the very first patient that we enrolled, it was a patient of mine in the Alliance trial, and then he was 74-year-old male. He presented to the emergency department with painless jaundice, and this was back in April of 2022. With reasonable past medical history, the CT scan showed a pancreatic head mass that was involving the first jejunal branch of the SMV, which by the NCCN definition is not considered a borderline. This is resectable. The EUS showed that pancreatic adenocarcinoma. So, and this is the CT scan. So how do I highlight this? So this is, you know, we place a metal stent. Don't ask me the reason, I don't remember. This is the pancreatic head mass. This is the SMA, which is completely free, and the SMV. It has some involvement of that first jejunal branch. So, you know, then we have management options. And I think at this point, even, you know, at this point, it's kind of varies according to the institution. I would say that perhaps with what we heard in London, we would not go to upfront surgery. This probably patient would receive neoadjuvant chemotherapy. FOLFIRINOX, a safe bet on a very healthy, you know, 74-year-old man. I was going to say young patient, but not that young anymore. And then I think in Hamilton Health Sciences, where I work, the answer would be upfront surgery. And then a PMH, Beatrice, this patient, it shows up today. What would you do?
Yeah, probably we will try to enroll him on the DORA trial, probably, but we will need to test the CA99 because one of the exclusion criteria is if the CA99 is higher, we cannot put the patient. But we will try to put him on a DORA trial, probably.
And we've started the DORA trial in our institution. We are open as of last week.
Oh,
And
oh, that's good.
we're very excited, and
Yeah.
we were closed. We had some issues with our clinical trials department. We were closed for a couple of years. We couldn't enroll patients at the clinical trials unit because everybody left to a better field. And then, but now that we are open, we decided to just finish enrollment of one more patient to, you know, Alliance trial, and now we're hopefully gearing our attentions towards DORA. So yeah, those were the options that I put in there, which is very interesting because every institution that we work in, it would be a different answer. So
Totally agree. Yeah.
hopefully we'll get some consensus.
Consensus.
Yeah, exactly.
Hard to know.
So this patient was placed in the PAC3 trial, and I was, you know, I was very happy the patient got into the chemotherapy arm first, and this is how I sell sort of the trial to the patient. I know I don't want to use the word sell, but like, you know, I want to introduce the trial to a patient, but I want to tell them what are the benefits of you enrolling this trial. And I think one of the most important things that I say is that, you know, you get the benefit of getting chemotherapy, which in our institution, you would not receive chemotherapy first. You would get it afterwards. So the only, you know, way that you can get chemotherapy first before surgery is if you enroll in this trial. And that is actually true. Yeah, I'm not lying to the patient, but this is just institutional based. Obviously, it would be different in different institutions. So he received the first 4 cycles, which is what they're supposed to do before the first CT. Unfortunately, he had a mechanical fall, so he fell. I don't think it's
Oh.
I don't think it's because of chemotherapy, but he fell and they had a fracture femur. And unfortunately, that led to a lot of delays in chemotherapy and a lot of delays in surgery. So, you know, eventually he was placed off the trial because he was way too far off the chemotherapy route, and then he underwent surgery in February 2023. So, you know, if we remember, this patient presented in May 2022, and about a year later, there you go, in May, and then about a year later, he went surgery with only 4 cycles of chemotherapy, unfortunately. And these things happen. You know, it's not, I don't think it was because of chemotherapy, but certainly it did happen. The pathology showed a T2 and 2, 4 out of 22 lymph nodes positive with negative margins. And then post-operatively in August, so that was, you know, but sometime after his surgery, he was not really able to get adjuvant therapy because his ECOG status was not great. It could be a mix of having received chemotherapy and then the patient fall, and then the patient had a surgery, and, you know, his disease progressed, and then he eventually died of disease recurrence. So that was my first patient on the PAC3 trial, and I said, well, the next one is going to be better. This is his patient when he presented. So the second patient was a 76-year-old female that presented with painless jaundice. Similar story in May of 2022, a high bilirubin and a normal CA19-9, basically. The ERCP was placed, and then, thankfully the brushings were positive, so we didn't have to do a biopsy, but most times it isn't. And the CT scan showed a resectable pancreatic adenocarcinoma. I try to get a better picture of this. But there's this very highly dilated bile ducts going into the hepatic artery. Looks very clear. The pancreatic cancer is somewhere in there, and the veins were clear. So this is maybe a different story, because this is not what we would call, in the first case, there was some involvement of the first jejunal branch. We could have called it borderline. This is really resectable. So I think, Dr. Leslie, resectable upfront surgery? Yes, CA19 was normal, 76, highly, despite being 76, I would say highly functional patient. It was also my patient. We random. I don't want to say that I'm the best person to put patients in trial, but we did have 13 patients enrolled in PAC3, and then 9 of those were my patients. Sometimes it's difficult to get patients in clinical trials if we don't have like a surgeon champion. So, in this patient that is resectable, I think probably is going to go either in a trial or upfront surgery. We would not be able to get the patient neoadjuvant therapy here. However, if you go down south, across the border, I think, I don't want to say everybody, but certainly I want to talk to Mayo Clinic. I want to say Sloan Kettering. I want to talk about the center in California. Many of these are given just neoadjuvant therapy, and dare I say that perhaps we don't have very good data, as we have been shown even from the latest meta-analysis, that neoadjuvant therapy in resectable disease is not great. I think we'll have a lot of information with this alliance trial in the next couple of years. Well, maybe more. The primary outcome for the trial is overall survival. So at least 2 years. So the patient was randomized to the PAC3 trial, and this patient was randomized to the chemotherapy first arm, which is, when you see your first patient goes into chemotherapy, I would say like, oh, you're for sure gonna go into this surgery first, but she didn't. She went into chemotherapy, and I said, well, I hope you don't fall. And she didn't. She received the 4 cycles, and then she got the CT scan. The CT scan is a mandatory CT after 4 cycles, and after that, you're supposed to go to 4 more cycles before surgery. Unfortunately, the CT scan after 4 cycles showed this, which was not present in the first CT scan. So I think these are the patients that perhaps are either not responding to FOLFIRINOX because of the CATA6, or because they already had metastatic disease, and I don't know. So we will see these patients as well. We will see these patients, and I don't think giving this patient chemotherapy was a bad idea. I think I think we saved this patient from an operation, but who knows. So then, chemotherapy was changed to gemabraxine, however, not really able to tolerate that gemabraxine very well, and then died shortly after. So the next patient is, the next case that we have here is another patient with painless jaundice. This is an older gentleman. He's in his 70s, presented with jaundice in October of 2022. An ERCP was placed. The biopsy showed adenocarcinoma. And then this is what we were seeing. It was also resectable. We talked about that. And then this patient was randomized to upfront surgery. So this is our 3rd case in the PAC3 trial. He was randomized to upfront surgery. So we said, we had really bad experience with the first 2 that underwent chemotherapy first. So this is, you're probably going to do better. The surgery went very nicely. This is not my patient. He did very well. He recovered nicely. He went home. And then after surgery, they usually have a CT scan before starting chemotherapy. And then it showed that. Yeah. So this patient probably had a futile laparotomy and a fetal Whipple. That thankfully it went well and did not really delay, but this is what we're seeing. So he was placed on palliative FOLFIRINOX, which is he never received before, and then now it's not called adjuvant because the patient has metastatic disease in the liver, and then eventually, unfortunately, also passed from progression of disease. He did not respond to FOLFIRINOX either. It's just a few months later. And the fourth patient is a different patient. This is a 75-year-old man who was being followed for a few years for IPMN without progression. So IPMNs are intraductal papillary mucinous neoplasia. These are pancreatic cystic lesions. We consider them to be premalignant, especially if they have certain risk factors. This patient didn't have high risk factors for cancer, so he was followed. Unfortunately, on the surveillance CT scan, he was found to have a solid nodule in the pancreas that is associated with the cystic lesion. So he had a biopsy and it showed adenocarcinoma. Some people say that these IPMNs that develop into cancer, they do have different prognosis. They might be a better prognosis than, de novo, I say, pancreatic ductal adenocarcinomas. And then this patient had what we thought in October of 2023, resectable disease. And then that was the image that was given to us. So we sent this in order to be randomized to the Alliance trial. You have two different components. So one is a pre-enrollment sort of session in which the study demographics, like the patient demographics, the CT scan is uploaded into a system and a central radiologist reviews it for control. This is also reviewed at our multidisciplinary rounds in our hospital, in which people like me, this was not my patient, but I review it and I say, yes, this is resectable and we can go ahead. So the patient was randomized in the PAC-3 trial to upfront surgery. The day of surgery, the surgeon reviews the CT scan like normally you would do. Before the operation, you want to know what you're dealing with. And then they find that that this is the cancer and this is the superior mesenteric artery, and then there is cancer next to the superior mesenteric artery. So we missed that. And then when we say we, it's like a whole lot of people missed this. So it's very subtle sometimes, and sometimes it's very difficult for us to understand what is cancer. So this was a big sort of like ooh-ha-ha moment in our department, because then we canceled the operation for the day of surgery, even though the patient was already randomized to surgery. You obviously put the patient first, and a patient that has SMA involvement, you're probably going to do a negative laparotomy because we're not going to be able to resect the SMA in that setting. So then we canceled the operation. Our story for PAC-4, PAC-3 is not great. So we canceled the operation. We took the patient out of the trial and we put him on FOLFIRINOX, and then we reassess. And then upon reassessment, unfortunately, we see that there's even more involvement around the artery. So this patient is not responding either. So then we changed the chemotherapy to gemabraxine, however, progressed. And then, earlier this year, the patient passed. So those are the four first patients to the PAC-3 trial that we had. We did not do very good. However, then we had the other 12 patients, the remaining 9 patients, and then we have better stories, and then we're waiting to hear from them to see what happens. But it's just a reminder that we're dealing with a very difficult disease. And then even though we're thinking that neoadjuvant chemotherapy may be the answer to our problems, it just may not be. We may have to find different sort of ways of treating patients. And I think the work that, Beatriz is doing at PMA, trying to find markers of response and biomarkers, is very important in order to do these, improve the prognosis of these patients. I think that's the last slide that I have. Thank you. Thank you very much.
I had a text from Ravi. He got pulled into rounds, or he's on call, but he made an interesting statement, because I I was texting him, telling him what we're talking about. And I said, you know, do you consider neoadjuvant consistent in Nova Scotia or in Atlantic Canada? And he said, more or less. But this was an interesting point, which speaks to, you know, the burden that the healthcare sector is feeling. It says lack of OR space means that we're often sending more for neoadjuvant because they can't get into the OR for those surgeries right away.
Yeah.
So they're turning to neoadjuvant, not just out of, you know, the benefits of neoadjuvant, but out of the need to get
I
the
think
patient.
that may be the right answer. We may hear in a couple of years that that is actually the answer, and then, you know, serendipitously they're just doing the right thing.
Mm. And I had one other question. So we talked about, you know, in another session about the clinical trials and getting patients into clinical trials. Right now, we have such a low, and you were talking about many of the patients being your patients and having a difficult time recruiting. As an advocacy organization, what can we do? Like, we've run the clinical trials Mythbusters for a couple of months, and I know that we work closely with PanCan. They're another founder of the World Pancreatic Cancer Coalitions. We sit on a steering committee and we have these conversations around the world. PanCan in the States dumped hundreds of thousands of dollars into clinical trial recruitment and education around the importance of clinical trials upon a diagnosis. We certainly see in Canada, it's not always equitable. We know where, you know, a lot of the clinical trials are across Canada, and many provinces not being able to access it. How do we, as an advocacy organization or organizations, because there's some online as well, how do we increase that enrollment in clinical trials? Like, is there any suggestions you have for us?
Yeah, you know, I think obviously this is a great question, and I did spend 8 years of my life doing a PhD in enrollment to clinical trials in surgery and in surgical oncology, and what were the barriers to enroll patients in a clinical trial. And then there's different factors that are involved. Are like patient factors. What are they interested in? Are surgeon factors, like, you know, if you bring a clinical trial to London about neoadjuvant therapy in patients with borderline resectable, this is not going to work. There are institutional factors, you know, in Nova Scotia. Can you get this patient to surgery right away if the patient was randomized into, well, no, we can't. So that's also, you can't go there. And some of those are not modifiable. There are some that we can change, and I don't know from, you know, an organization perspective, really, because that was not my area of expertise. But what I did find is that the surgeon opinion and the surgeon attitude towards a clinical trial is very important. So the patient meets the surgeon for the first time in their lives, and the patient has a big problem in their life. You know, they have pancreatic cancer, and they come to a surgeon, and they will really follow what the surgeon tells them to do. And it doesn't matter. And I would come in and talk to them about the trials, but if the surgeon already said to the patient, you're going to get surgery next week, and this is the best thing ever, there's nothing that anybody in the world can say to, and an organization comes into play as well. There's nothing that they're going to say to the patient to change their mind, because they want to follow and they trust their surgeon, which is good. They should trust their surgeons. But I think it's that we have to change that mindset of the surgeon, that clinical trial is actually a good thing for patients, because this is the way to advance knowledge. Because the surgeons will follow what the patients will follow what the surgeons do. And then if we are able to sort of teach surgeons in sessions like this one, in which we learn from clinical trials and we give them the importance of clinical trial, and that conversation, the first time that the patient and the surgeon have a conversation, changes, in which the surgeon says, okay, I can do surgery, or you can go into this clinical trial, which I would favor, because we don't have an answer for, you know, what is best. This is the reason that we're doing the clinical trial. And I think that sense of doubt helps the patient make a more informed decision. What we do in our centers is that we have a big clinical trials presence. We have a lot of research assistants in the clinics. And we talk to the surgeon when they are in clinic, and if they see a patient that they think is eligible, we ask them that please introduce us right away so that we can talk to the patient right after they talk to them. But most importantly, we want the surgeon to remember that there is a clinical trial, that we can do something for this patient other than the standard of care that may or may not benefit, but certainly would improve our knowledge on how to benefit other people.
That's Ravi was also just texting that about the importance of having those collaborative discussions. So he started that in Nova Scotia with the surgeons and radiologists and the oncologists, so that when my dad was diagnosed in 2006, they didn't have that, but those table discussions with all the experts at the table that are servicing those pancreatic cancer patients are constantly hearing about the clinical trials. They're updating their pathways. And I said to Ravi, it has to be a national pathway, stop the Atlantic Canada. But it's getting those, I keep saying those pathways, but I think putting that information that's been agreed upon across Canada as a national standard, that would also maybe start those conversations if it's, a standardized, pathways. Would it not? I don't like,
I think bringing information to the surgeon and the community that a clinical trial is something that is actually important to consider as a pathway of clinical care, that certainly changes the way that we speak with patients. So the group of surgeons that I work with today, which are the same surgeons, compared to the people that I started working about 10 years ago, are very different. The surgeons that I work with today, they are interested in the clinical trial situation. They are looking towards clinical trials as a solution for treating their patients. And I think that changes because they have more information about clinical trials being an option for their patients. And, it didn't just happen overnight. I mean, there's a lot of work behind that, in which I have to remind them. And then there's a research assistant right next to you. It's right here. If we have a clinical trial, it's important. But I think the more information that they receive, is the more knowledge that they will have, and then the better way that they can take care of their patients in a clinical trial.
We have I think I've spoken about it. I can't remember where I was or when I said it, but it's been too many events in a short period of time. But we do have a clinical trial finder for pancreatic cancer patients on our website that has patients matched with a PhD student to help them find a clinical trial that they're eligible for within a distance that they're willing to travel. But what we're also coming up against is that many of the clinicians have only a few moments with each of these patients that are lined up outside their office. So even when the patients are advocating for clinical trials, quite often the oncologists don't always have the time to go through those clinical trials to decide which one was, best for their patient, or the patient met most of the eligibility in it.
Because I think it goes back to the point. I don't think it's a patient problem. I think it's a clinician issue that this is what we have to tackle.
Yeah. Is there any other questions? I'm behind again. Do you have a question? Come on up.
Consider myself a trial of one. But I do provide a lot of peer support for recently diagnosed. And so I'm aware of the differences of the decision. Do you get chemo first and then surgery, or surgery first and then chemo? I'm a strong proponent for surgery first. And I'm really glad that my surgeon agreed when I said, get it out. If it looks like a duct, I didn't even go for a biopsy. Didn't want to wait, which turned out to be the best decision for me. So I guess in all of this conversation, which I really do respect, and I'm very supportive of trials and research, I think the patient voice has to be taken into account in all these decisions. Because of my history, I knew how devastating pancreatic cancer can be, and I did not want to take the chance. The second comment, and you touched on it, but it just goes back to my oncologist that I had this love-hate relationship with, and I apologize for all the oncologists in the room. I do actually care for them a lot. But with the decision of kind of the two streams of types of chemo, it always seems to be that you have to have 12 treatments, whether you do, 6 and 6 or 4 and 8 or all 12 at the end, whatever. But, and I'm a past auditor, so it got in my head. I did not take 12 after my surgery. And has there been studies to determine why 12? What's the magic of 12? And when I spoke with my oncologist, he said, I should stop at 8. And I said, but you said 12. And he goes, well, we don't really know if 4 is going to do any more. So we know that for me, for Florindex, I had lots of side effects in having that treatment. But has there been, or should there be, some studies as to why 12? So why do we have to have 4 in the front and then do 8 afterwards? Like,
I'm very curious, Beatrice. Do you have
like
some
I just
thoughts
don't,
on
I
that?
don't know why
Yeah,
there
for
hasn't
sure.
been.
But also because like the neoadjuvant approach is only 8. I was like, what is it 8 instead of 12? I don't understand. But Beatrice, what's your thoughts? Oh, did we lose her?
I think you're muted.
Oh, hi, Beatrice.
Can you
Yeah.
hear me now? Oh,
Yes.
so sorry. I don't know what's happening with my microphone. I'm so sorry. I was telling you that this is a pretty good question. I mean, regimen in terms of length are based on the priors. I mean, one of the most past trials that it has based on maybe one molecule. It was being done for 6 months. And at first, I think they are developing also based on other kind of tumor that we have, colon cancer, gastric cancer. They are also regimen based on adjuvant 6 months, also neoadjuvant 3 months, and adjuvant is other 3 months. So I think they are coming from there for other GI malignancies in which neoadjuvant and adjuvant treatment has been studied more in advance when this study just wasn't coming out. So all the studies in which FOLFIRINOX is assessed, they all point out that there is a percentage of the patient, I don't remember exactly, but around 20 to maybe 35 patient, if we just focus on one study after another, in which they say that the patient cannot complete. I mean, so when it's kind of this. So when the patient completed, when the patient are assessed to start adjuvant or neoadjuvant, in this case, adjuvant treatment, we are assessing to try to finish 6 months. It's because the protocol just tell us to do that, but we know that there are maybe around 1/3 of the patient that doesn't complete the treatment. And we haven't been studying if this impact in the survival, in the patient survival, which I think it could be a good study design regarding that. But I think our main focus is how fit is the patient and not developing more side effects. So in terms of the length of a study, I think it's pretty much protocolized based on other malignancies. So it has been made it that way, but also all of the study, or the vast majority of the study, assess the side effects, especially with FOLFIRINOX. In fact, I think there are some of the French group, the German group, in which they are trying to demonstrate that these regimens, not only with FOLFIRINOX, but also they are more, I think they are more studied with gemcitabine regimen, that they're trying to demonstrate that they can be as better as FOLFIRINOX in terms of survival outcomes, but without any that kind of side effects. So it's kind of difficult to assess. And even if we tend to use FOLFIRINOX because the overall survival seems to be the better, if you tend to compare the study that we have based on overall survival in terms of FOLFIRINOX versus gemcitabine monotherapy, we don't see really the survival benefit in terms of total numbers. So I think they are trying to combine some other teams without any more side effects, some of the groups, and there are other trend which is trying to maintain the FOLFIRINOX with other kind of regimens. But we know that most of the patient, I wouldn't say much, but it is going to be 1/3 of the patient in terms of probability that are not going to finish the team 6 months.